we will now go for a presentation wherein case-based discussion. I'm sorry I had some work and could join very late. So anyways, so the panelists who are here can they just introduce themselves?
Sir, I am Lieutenant Rajesh Arnaya, sir.
Sir, Dr. Deepak, sir.
I am Dr. Dubek.
Dr. Amrit here, sir, Rajiv Gandhi Cancer Institute.
Okay.
Dr. Kaushik, sir, from Ashwini.
Okay, so that's great.
And also we have Dr. Arnav also, sir. He was previously at Army Hospital, Aranda.
Okay, that's great. Okay,
and
so
Dr.
we'll
Sujana
go
also.
to this. Okay, fine. So we'll go for a case-based presentation. And I had this case of 57-year-old male, well-controlled hypertension, otherwise well, presented with cough and weight loss of 1 month duration. Clinical examination was occasional wheeze in the chest, otherwise seemed everything normal. A CCT thorax was done, which showed a 4 into 3 into 3.7 centimeters spiculated mass in the left upper lobe. And there was a left hilar lymph node 1.5 into 2 centimeters. So naturally, we got a biopsy done. The biopsy was an adenocarcinoma of the lung. So we went ahead with a metastatic workup, which showed that the PET CT, we got it done, which showed a left upper lobe mass, left hilar lymph node mass, 1.5 into 2 centimeters, no other uptake anywhere. MRI brain, there was no evidence of any metastasis. So how are we going to proceed here? We'll take it off with Dr. Kaushik. What do you feel?
Sir, by the history given, it like to be a T2N1 disease, sir.
Yeah.
Early stage lung cancer, and PET is negative, sir, for the distant metastasis. Now, being a T2N1 disease, MRI brain has been done, sir.
It has been done and it is negative.
Sir, now we need to proceed with the mediastinal evaluation, sir.
Okay. So how do you plan to do that, mediastinal evaluation?
At present, the EBUS directed can guide us because there is a left hilar lymph node. So EBUS guided biopsy, so it can help us for clearing the mediastinal evaluation and then further procedure.
So Dr. Amrit, what is your take about how to address the mediastinum?
Yes, sir. So in this case, the imaging workup has been done. Usually we do PET and MRI in early lung cancer. So before proceeding to any definitive management, definitely you would like to do a mediastinal staging. That is usually by endobronchial ultrasound and TBNA. Okay. And if that comes negative, then we can, if it is just an N1 node, we can go ahead with a surgery. Or if the suspicion of being an N2 node is very high on the basis of imaging and initial EBUS was negative, we can do an invasive mediastinoscopy before surgery. If that also comes negative, then we can go ahead with a surgery, sir, if the suspicion of an N2, N3 is high.
Okay. So, Nair, what do you feel at your center? So, do you go for a mediastinoscopy or do you go for a guided evaluation of the mediastinum?
The first thing that we have to do, since there is a N1 lymph node, which is PET a bit, EBUS plus
Dr. Nair is there?
Sir, am I audible, sir? Hello, am I audible, sir?
Yeah, you are audible.
Sir, first we have to do first thing, since there is an N1 lymph node, first thing that we have to do is that EBUS plus lymph node sampling, sir. If it is negative, then we have to do a thoracoscopy and then sample, sir. Hello.
Okay.
Hello.
Dr. Arnav, is there any trials that are there? Dr. Arnav's around there? Okay. Are there any trials? Yeah, hello. Yeah. So are there any trials which have compared mediastinoscopy and EBUS guided TBNA? Okay. So
Dr. Arnav, you have to unmute.
mediastinal nodal evaluation, like everybody said, is what we'll be doing.
Sir, actually, what we used to follow in our center that, sir, N1, at least if it is positive, and if it is PET away, we will definitely go with a mediastinoscopy, sir. The mediastinoscopy won't be a traditional mediascopy, but a video mediastinoscopy, in which we evaluate up till the level of the carina. So, as such, sir, because before proceeding with surgery, because in this case the surgery will involve the whole of the lobectomy along with a proper mediastinal nodal dissection. So I think so mediastinoscopy would be a preferred method to not to miss any suspicious nodes, sir.
Okay.
Because EBUS guided FNSC has got a high false positivity rate, around 30%, I think so.
Okay. So anyway, the recent trials have all come out in support of EBUS guided TBNA, and these days you consider that good enough investigation. But there are centers and people still, some centers would like to go with a video assisted mediastinoscopy. But anyways, the recently almost centers have been moving to EBUS TBNA, and there is data to suggest that yes, it is as good as, if not better than, the video assisted mediastinoscopy. So pathological stage had come out to be N0. So right now, we would of course go in for the surgery. But before surgery, any thoughts, anybody on about any role of neoadjuvant therapy under these settings? Dr. Amrit?
So probably if it is in a clear-cut resectable D2N1 disease, I think not at this point of time. We definitely go ahead with the surgery first, then look at the pathological stages, then decide upon the adjuvant treatment.
Kaushik, why do you think we are even considering neoadjuvant therapy? I mean,
Presently,
what is the ratio for this?
maybe to check out the path response as we had seen in some breast cancer, some data coming up with immunotherapy usage in the resectable or N plus diseases, where we can use the nivolumab and then go ahead with the. There seems that there is an improved path response in the neoadjuvant nivolumab. It has been FDA approved also for the same indication.
Yeah. Okay, so what you out is quite right, but the only thing about this is, for a curative disease that we speak of, the survival is not that great. And even after undertaking most of the therapy, we still find that we are not getting the desired survival. And that is the reason why, even in early lung cancer, there have been various approaches to try and improve the survival. So if we look at it, can we probably identify targets at this particular point? When you have a biopsy, would you send it for molecular analysis? Or would you rather wait till the surgery has been done? So, Dr. Shiv Shankar, what are your thought process on that?
Sir, depending upon what is the modality of therapy we are choosing, if we are choosing for neoadjuvant therapy, particularly given that tolerating adjuvant therapy post lobectomy or pneumonectomy will be a bit difficult. So probably that is the reason why we are moving towards neoadjuvant therapy. And also recently, nivolumab plus chemotherapy has shown a very good pathological response, even CR rates. If you are going for a neoadjuvant therapy, definitely I'd like to get a biopsy and also get done these biomarkers like EGFR, ALK. At least we know that in those set of patients, immunotherapy does not do well. If we are going for upfront surgery, I'll wait for final histopathological surgical specimen to look for this molecular analysis. Depending upon whether we choose neoadjuvant or we go for upfront surgery, depending upon that, I will decide whether to go for molecular analysis upfront or not.
Do you expect it to be different from the biopsy specimen and from the resected specimen?
I don't think, I mean, heterogeneity is less in lung cancer, I believe.
Yeah, so it is that you're right. So now, what about neoadjuvant EGFR targeted therapy? So, Dr. Arnav, I'll come back to you. Okay, Dr. Nair.
Sir.
Hello. Yes, sir.
Yeah.
Can you hear me, sir?
Yeah, now we can.
Yeah, sir. So I think so. EGFR targeted, sir. There has recently been a trial outcome. I think so it was the ADORA trial, which has recently come out with osimertinib, I think so, in EGFR targeted therapy, and found that there was significant survival benefit with neoadjuvant therapy for EGFR targeted, even in early uh, lung cancer, sir. So I think so. Definitely, the role of neoadjuvant therapy in EGFR has come up.
You're talking about ADORA study, new ADORA study that is yet to come out.
I think so. The one where the result has been published, sir. I think so.
So, Dr. Dubey, if you are there, maybe you can tell us about the role of any EGFR targeted neoadjuvant therapy.
Sir, presently we don't have actually concrete data, though the trial is, I don't know the concrete data, whether it has come out or not, whether the trial is, I guess, on the way. But yes, adjuvant data is out. That is the ADORA trial. That is an adjuvant study for the patient with completely resected either post-adjuvant chemotherapy or without chemotherapy. But in this patient, sir, I will not be in favor of giving any chemotherapy until unless the tumor board decides that patient is not fit for surgery and they want to assess it later for that whether the patient will be fit for surgery or not. Means patient is medically operable or not. I feel so the patient is medically operable, so I'll not consider neoadjuvant. And also in N2 disease, the N2 disease and T4 tumors, the neoadjuvant therapy has been tried for, but it has not improved the survival in at least 2 trials. So I'm not, but I don't know that what targeted therapy will do and what will be the outcomes with targeted therapy. This field, I'm also yet to know this.
I quite agree with you. The case is very simple, but then I need to discuss something, isn't it? So that is the reason for all these questions. So even my surgeon would probably kick me if I tell him that I'll give him neoadjuvant. But still, I thought neoadora, I think, is trial is still on, and I don't think the results are out.
Yes.
The ADORA.
Sorry, sir. I thought about the new adjuvant. So adjuvant therapy, ADORA was the trial results have been out, not for the new adjuvant. Yes, sir.
You're right. It is the adjuvant which has come out. Yeah. So it is not the new adjuvant. New adjuvant trial is still on, and we should probably wait for that trial to come out. So this is the trial that is going on, and once it comes out, then we'd probably be able to see. So IO in neoadjuvant settings, Kaushik has brought it out. He says some data for it. And yes, there are some preliminary data. And if you look at the images, if they are seen, you can look at neoadjuvant PD-1 blockade in resectable lung cancer. If you actually look at the images pre and post, you can see that there is a lot of shrinkage of the tumor. Even the biopsy specimen pre-treatment and post-resection, there seems to be a lot of pathological response as well. So yes, that might be coming in the future, but right now we cannot recommend it, in particularly in the case that we are looking at. So primary endpoint was, of course, pathological CR. Any role of radiation in this?
I think we have Dr. Ismail from Radiation Oncology. I think he can take up this question. Sir.
Yeah, Dr. Ismail, that's great. You almost said.
Hello, good evening. My name is Mohammad Ismail Sharif. I'm a radiation oncologist from Rajiv Gandhi. Am I audible?
Yeah, you are. Please.
Okay. The role of radiation in a completely resected tumor, I don't think there is any, beneficial outcome with utilization of radiation. If the patient has undergone surgery and there is no indication that with respect to like positive margin and all, I don't think radiation has any role after complete surgical resection.
Okay. So any role of Saber? I'll stick with you because you're the radiation oncologist, Ismail. So,
Okay,
any role
the
of this?
role of stereotactic ablation in radiotherapy is quite upcoming. It's there are various trials which have suggested that in those patients who are not eligible for surgical resection can be taken up for SABR, and they have shown to have very promising results. The control result, I mean, the control is up to, especially when the node was proven to be negative.
Okay.
I hope the node was proven to be negative, right?
Yeah, it was proven to be negative.
Then the utilization of SABR can be utilized, but the problem is the size criteria. I think the size which was mentioned in the beginning was 4.5 centimeters.
Yeah, you're right.
And yeah, and also since it is radiotherapy which we are going to implement, I mean to say we'll need pulmonary function test analysis also sometimes. SABR has a beneficial outcome. I totally agree, but size, sorry?
In this case, would you be offering it to your patient?
Yeah, I can offer if the patient refuses for surgery. And
Or
if
patient
is
inoperable, I guess.
inoperable,
Yeah?
exactly.
Medically inoperable, right?
Exactly.
Okay.
Exactly.
So in this case, yeah, I'll come back to Dr. Arnav here. What surgery would you be planning?
Sir, notes are negative, then sir, I will definitely plan for a upper lobectomy along with the whole mediastinal lymph node dissection, sir.
Okay. And
N2 till N2 level, sir.
okay. Do you think there is a role wherein we can probably just do a segmentectomy? Have we reached that stage in lung cancer where we can probably get away with just segmentectomy or things?
Sir, Japanese surgeons are doing it, sir, regularly. I think so for small segmental tumors, sir. But still, we are not very comfortable. I don't think so. We have come to the stage that where a 4 centimeter tumor, maybe, sir, a very small 1 or 2 centimeter tumor in the periphery of the peripheral tumor, sir. Maybe we might plan, but still, sir, I think so. Anatomical dissections have got the advantage of getting the nodes also, which might be left if we do a segmental dissection.
Yeah.
That is what I feel, sir.
I think you have summed it quite well. But there are trials going on, and like you said, in most of the East Asia part, there are a few trials coming for more localized excisions, wide local excisions, rather than for going for lobectomies. Anyway, this patient of ours underwent a left upper lobectomy, was again adenocarcinoma, 4 into 4 centimeters, node negative. Now, Kaushik, what do you think about adjuvant therapy that you would like to offer to this patient?
Sir, there is absolutely he is in stage 2 disease. Sir. The benefit of adjuvant, based on the previous LACE meta-analysis, he has a 5-year survival benefit with the adjuvant therapy of 4 cycles. At the same time, we will be better to wait for the molecular markers, EGFR at least.
So, first coming to the question of chemotherapy, do you think that the chemotherapy at this stage would actually make a difference to the final OS?
Sir, with the Aurora trial, sir, they had.
No, I'm talking still about chemotherapy. Much
yes.
as I would like to move to targeted therapy, I'm still stuck up on chemotherapy. Whether I should actually offer this patient chemotherapy is the question.
Sir, though it is a N0 disease, sir, but based on some risk factor, it fare better with the adjuvant chemotherapy. So like size here, it is around 4 centimeter plus. So one of the risk factors. So he would be benefiting from the adjuvant therapy.
He's barely touching 4 centimeters. I mean, he is 4 centimeters. So purposefully, I think I have kept it at 4 centimeters. So otherwise, it would have become too easy. Dubey, what do you feel in this patient? Would you offer adjuvant therapy?
Sir, it is T2A, so it hasn't even become stage 2 yet, I guess, if I'm not wrong. It is T2A because it's not more than 4 centimeters. So I'll note that with the LACE meta-analysis of 5 trials, in stage 1 trial, stage 1 disease, the adjuvant chemotherapy has not shown much benefit, only 3% additional benefit with the adjuvant chemotherapy. So I am not of, if it is T2A, the slightly numbers can vary. If it is yes, it becomes, as per me, it has not become stage 2 yet. So if it is stage 2, yes, I'll give, because the additional benefit will become around 10%.
Okay. And Dr. Shiv Shankar, what do you feel? What is your take on this? 4 centimeters. The pathologist is sticking to 4 centimeters. T is equal to 4 centimeters. What are you going to do about the adjuvant therapy? N0.
Sir, I agree with whatever Dr. Dubey sir said, that I mean, it is a borderline case. It is cut off less than 4 centimeter. There is no role more than 4 centimeter. I also look for other poor prognostic markers, like is it poorly differentiated? Is there LBI? If there are any such soft targets, I tend towards giving adjuvant therapy. Otherwise, no, sir.
Okay. And would you go ahead and do molecular testing in this case?
If I'm planning adjuvant therapy, definitely yes, sir. In that case, I'll also look for EGFR, all PDL1, all these markers I do look for, sir.
That's an interesting point that you have mentioned. Nair, would you be doing ALK and PDL1 along with this case?
So right now in the adjuvant setting, we have approval for immunotherapy and EGFR. So here I'll be going for EGFR mutation plus PDL1 and some other things like KRAS and P53 mutation, to see whether they will definitely benefit, whether they will have any benefit to adjuvant chemotherapy, like P53 overexpression tumor, they have some response to chemotherapy, while KRAS mutated, they have less response to chemotherapy. So I'll be sending the specimen for EGFR and PDL1.
Dr. Dubey, let's suppose that this patient was translocation for ALK was positive. Would you be tempted to use ALK directed therapy in this case?
Sir, I would be tempted for sure to use that ALK directed therapy in this patient, if patient will be ALK translocated or ALK rearranged. Though we don't have, though the trials are on their way, and but again, I guess so there were no results are out.
So if you would give ALK positive, ALK directed therapy, how long would you give it then?
So for 1 year?
For 1 year, okay. So let us see. We discussed this, and this is our patient turned out to be EGFR mutation positive. And now, would you think about giving osimertinib, considering that this is the data that is available right now with TORA trial coming out? Would you be definitely giving every osimertinib with this? Dr. Shiv Shankar, please.
Sir, definitely. I mean, data is very, very promising. Though we do not have a overall survival data, the PFS data is, the magnitude of benefit is huge. If cost is not an issue, definitely I'll go for adjuvant osimertinib. Definitely yes.
Dr. Dubey, when you are looking at curative settings, do you think PFS is a good enough parameter to decide our treatment?
Yes, sir. PFS and DFS, though, I guess they both are good enough. Because lung cancer is a disease, I mean, any cancer is such a disease where whatever outcomes we are getting, we must actually respect that. What I think, that's my opinion, and we should go ahead with that, sir.
Okay. So you would rather not wait for the OS data to come out in a...
Sir, I have this hazard ratio of such hazard ratio I have not seen in many survival curves, the hazard ratio of 0.20, 0.23. So these are very difficult to see in trials. And when we are seeing this in trials, although at early stage lung cancer, we must respect that, and we should offer to the patient if they are affording it.
Okay. So I will what about IOs? We'll come back to Kaushik, because Kaushik started the IO business. So Kaushik, what do you think?
So prior to this, one point on the urgent osimertinib, sir, I have to submit, sir. The
Okay.
trial ADAURA, which had maximum benefit of that hazard of 0.17, was in the stage, the 3B, this was the 3A. If you are taking it's the stage 1B disease, then the hazard was 0.5, sir.
Hazard of 0.5 is also quite a significant hazard, but your point is well taken, actually. Your point is very well taken, but let's come back to the IOs. What do you feel?
That if with the therefore if the PD-L1 expression is there, then presently we have data with the atezolizumab with a good event-free survival. Again, the OS is not matured enough, but there is a event-free survival data. But with this driver mutation positive, then it's no much of use.
Okay, fine. So we will go for this atezo. These are the curves that we have seen. Again, we'll skip that right now. And if you look at the forest plot again, stage 2A, probably stage 3A is where it doesn't cross the line of unity. But otherwise, okay, there's still data coming for that, and probably something we need to keep in mind. So we started the patient on chemotherapy, and due to certain this thing, we haven't still offered him osimertinib, and the patient is on adjuvant therapy. I think I have finished with the case, and I would like to thank all my panelists for bringing such I would like to hand it back over to the organizers, please.
Thank you, Deepak sir, and thank you all the panelists for their wonderful contribution for a very exciting case-based discussion. And I think Deepak Molajkar sir has brought about very important practical issues in the management of early stage lung cancer. Sir also covered a role of both neoadjuvant immunotherapy as well as adjuvant chemo, immuno, and also targeted therapy very nicely. I hope there are no doubts about the case-based discussion. With this, I